So welcome everyone to this June Let's Code Together session. My name's Jane Knight. I'll give you a wave, those of you who are with us live. My name's Jane Knight and I'm a clinical associate with the MedDRA MSSO. And I'm also joined today by my colleague, Dr. Caroline Wilson, who's one of our medical officers.
Hello, everyone, and a warm welcome from Berlin in Germany as well.
So the first slide just explains that MedDRA came about in the mid-1990s. It was an ICH initiative, and at the time, the MedDRA MSSO was put in place to maintain and distribute MedDRA. The activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, both the industry and the regulatory authorities. The next slide is a copyright that explains that MedDRA is owned by ICH, as is the material today. We don't make these slides available as slides, although the session will be recorded and will be available on the YouTube channel, assuming that all the audio is correct with everything. So if you do quote anything or use anything from the presentation today, you must acknowledge ICH as owners of MedDRA and of the material. I was explaining to those of you that are here early, we want the session to be as interactive as possible, and we do urge you to participate. We can do this in two ways. One is through using the questions panel in the GoToWebinar, the questions or chat, it might be labeled, and you can give us your comments on the verbatims as we go along. You can also join us with our polling tool, and the polling tool I'll come to shortly. Sometimes we may not all agree, so when you do give us your comments, we may not all agree on the term selection, and in the interest of time, we may have to agree to disagree. But another comment is that we cannot take requests to code specific verbatim terms today via the questions, but at the end there will be a survey link, and this is your option to give us new terms or new examples that you'd like us to address in future sessions. I can't guarantee when it will be. What we've been trying to do is to group topics so that we address a theme in a session, but we've been putting the verbatim terms out ahead of time, so you'll be able to see if one of yours is coming up. Today, almost all of our examples have come from previous attendees who've proposed examples for us to discuss. This is our polling tool that you may have used before if you've joined us on a previous webinar. You can do it either through your mobile phone or on a computer. You need to open an internet browsing session and you type in the top polev.com. You type that into the URL, nothing else, just polev.com. Then when you get to the logon screen, you enter my name, Jane Knight 855. That will allow you to join our presentation today. You don't enter your own name. It's completely anonymous. But alternatively, if it's easier for you and you've got your phone to hand, you can scan the QR code and it will take you straight in. So if you scan the QR code from the screen here now, you'll be straight into the polls. And if you do forget the details of the polls, the credentials are in the chat panel. So here is an opportunity, and I see a lot of you have started already to see. We see a couple of you from Europe, but generally, there you are from the United States. Good to have you with us, as we'd expect for this time of day, across the whole span from east to west coast, wherever you are, and in Canada. So welcome, wherever you are in the world, you're very welcome. We'd like to give you the opportunity to use a browser during the session to help your learning. And to do this, we've created a temporary demonstration password. So if you don't have access to a browser, you can log on through the MedDRA homepage. You see at the top right-hand side, there's a link to the WBB web-based browser, and that will take you to the logon screen. And these are the credentials you can use to log on to the browser. This is just so that you have a tool available for you to hand in case you don't have your own password or you don't have your own screen. Okay. So you can take a snapshot of that perhaps or write it down, and Caroline's putting it in the chat for us. So then in coding, sometimes there are challenges. There may not always be an exact match. Sometimes there's more than one possible approach. And even the points to consider document sometimes give us options with a preferred approach. Sometimes it's a case that we understand terms differently. I can read a term, and sometimes Carol Ann, when we talk about it, will see that term in a different way. And so it is often with coders. So what we have to do, often we can't find an exact match, and what we're doing is making what we would like to call a best approximation. But overall, we always code as reported. We don't make assumptions. We use medical judgment, but we don't use assumptions. And this is an example. We always include one of these pictures in these sessions to show you how, just as I could look at this picture and what am I seeing? I'm seeing a large bird carrying some sort of animal, looks maybe a sheep, and he's standing on a patch of grass. If you look at it the upside down and we turn that picture, who's to say what's correct? Here I'm seeing a man reclining in a boat next to a big fish with an island, and he's got a hat on. So this is what I'm seeing now. You can see there the difference. And it is just like that with verbatim terms. I can look at a term and think I know exactly what it means. And it's only when I speak to one of my colleagues I see that there's another way of viewing it. So it's all about medical judgment, a balance between applying the coding rules for consistency, but also using medical judgment in order to manage patient risks. Medical references are essential, and you'll see that today as we go through some of the examples. Sometimes you also find that we can't find a term in MedDRA for the concept, so we end up having to ask for a new term to be added, making a change request. So having said all of that, I'm going to turn my camera off now because I find it distracting, and let's code together. The first example we have today is muscular rib pain across the left side. Is this verbatim clear enough to code? This is the first question we ask ourselves. What's the site of the pain? Are we clear? Well, it's ribs, isn't it? And the nature was telling us it's muscular pain. So we're thinking, can we find a term? What's the appropriate LLT? Maybe we may need to think about synonyms. So this is the first example. What would you code that to? If you forget what the verbatim said, Carol Ann's put it in the chat for us, so you can refer back. If you open the chat panel, you'll be able to see. Somebody's suggesting intercostal as the site. Well, intercostal are the muscles, aren't they? So intercostal pain would seem to be a good option. Rib pain, well, they've told us it's ribs. So again, that's good because it's capturing the site of the pain. Musculoskeletal pain, a bit more general there, where you're right that it's capturing the muscles and the bones. Intercostal myalgia, somebody's found a term that captures both the site being intercostal and the nature of the pain being myalgia. Muscular pain and rib pain, someone else is going to try and split it, proposing to split. So various options there. Hopefully everybody's had chance to vote. If you have voted, rib pain and intercostal pain. So you're picking up exactly the things that would cross my mind when I first look at that term. Another vote for intercostal myalgia. That does look like a good option. So let's go to our browser and see. So I'm going to go to my browser now. Here we are. I'll go to the web-based browser, just as I suggested you do. You can use the training login if you don't have a login. And let's see what we've got. So we know it's rib and we know it's muscular. So I'm going to try with muscle pain first. Musc pain. See if I can find muscle pain and see if there is anything at the ribs or intercostal, somebody suggested. So there's nothing with muscle pain. There's just there's muscle pain itself, the LLT. So let's have a look at that. That has a PT of myalgia. When we look at the hierarchy, it has a PT. So maybe we should look with myalgia as the synonym. This is how I would approach it. Have a look at myalgia and see muscle pain doesn't have anything relating to ribs. Is there anything? And this is maybe what some of you have already done in doing your homework. And there it is, myalgia intercostal. That's the term that you highlighted. That seems to be the best match. It's under the HLT of muscle pains. So it's very important. Therefore, that makes me think that MedDRA does prioritize the site in terms of pain, the muscle, the nature rather, I should say, rather than the site, the muscular nature of the pain, and we're able to capture intercostal at the LLT and the PT. So that would be the best match as far as I can see. Let's go back to our slides here. Let's close some of these windows. I see I'm a bit busy there. Muscular pain across the left side, rib pain. We would identify the pieces of information provided, as you saw us do, and look for an LLT to capture the site and the type of pain. And a few of you beat me to it there. Some of you were suggesting that we split the term into rib pain and muscle pain, but it's telling us it's muscular pain. So it's not actually the ribs that's painful. It would be the muscles in between. So you don't need to split when you can find a combination term in MedDRA, as we have intercostal myalgia. Use the synonyms as you saw me do with myalgia. And then we come to the final suggestion being myalgia intercostal. Well done. Well done. Thank you for your input. So with that, I'll hand over to you, Carol-Ann, for our next example. Do we have any questions? Yes. I should ask before we move on. Are there any questions for that one? Looks like people are maybe giving us their suggestions. You can give your suggestions.
So just suggestion, no questions.
Hopefully you can. Hopefully the polling is working for some of you. So thank you. Over to you, Carol-Ann.
So here I am. So this next verbatim relates to a post-procedural event that we carried over from the last session. It is reported that a patient suffers right chest discomfort from a pleural catheter. What is causing the discomfort in this instance? So is it the insertion procedure? Is it a discomfort at the catheter site? Or is it more than that? Can we find a MedDRA combination term that would cover the relationship of the chest discomfort to the device or to the procedure? Or do we need to split? When checking for guidance in the PTC document for MedDRA term selection, this is what you can find for coding of post-procedural conditions. We are told that MedDRA contains post-operative and post-procedural terms, quite a number of them, and that we should select the most specific term. The given examples are straightforward. So bleeding after surgery should be coded to bleeding post-operative, and sepsis occurring after the procedure to post-procedural sepsis. So what to do when no such term is available? There is no guidance in this document. What to do then? So which LLT would you select for our verbatim right chest discomfort from pleural catheter? What would you select? Just chest discomfort and ignore the fact that it is related to catheter, to the pleural catheter. Would you select medical device site discomfort, very local reaction? Would you rather assign medical device discomfort, so more general term, but then you would lose the exact localization of the discomfort, the chest? Or would you split into chest discomfort and post-procedural complication, or chest discomfort and catheter-related complication? What would you do? So I see that most of you would split into chest discomfort and catheter-related complication. But we have split of opinions here. Some also would only go to chest discomfort. So the majority is going for the last option, to split into chest discomfort and catheter-related complication. Let me lock the poll and let me switch to the browser. Here we are. So let's check. How would we approach this verbatim? We would first look for chest discomfort and search and see whether we find a term that somehow combines the chest discomfort with the procedure, post-procedural event whatsoever. But we see there's nothing. Chest discomfort, chest wall discomfort are the only options that we have. So what about medical device discomfort? Oops, no typo, otherwise you won't find anything. And search. Here we have the medical device discomfort. And if I go to the browser, right mouse click, then I see medical device discomfort is grouped under complications associated with device. And we also have the medical device side terms underneath. Here's the medical device side discomfort, so very local reaction here. Also, we have a catheter side option. More specific, because we name the exact device, catheter side discomfort would also be an option. And this is grouped under catheter side related reaction. So here we would lose the exact event, the condition of interest on the PT level. What about catheter complication? Catheter-related complication. Again, it's under PT complication associated with device. And then we have another one, a respiratory complication. Respiratory complication associated with device. And this is also the same name for the PT. So these would be all the options that we have to code this event, medical device, so discomfort, chest discomfort from the pleural catheter. And you see that when assigning the chest discomfort only, we lose the relationship to the pleural catheter. And with the medical device discomfort, we do not capture the anatomical side, which is affected by the discomfort. The medical device side terms and also the catheter side terms may not be appropriate because the discomfort could affect the whole pleural cavity due to drainage under suction, resulting in a negative pressure in the pleural cavity. So there is room for interpretation whether the catheter side terms can only be applied for local insertion site complications or events, or to the whole anatomical site in which the catheter is located, here the pleura. When assigning the LLT catheter-related complication only, we lose the actual clinical symptom, the chest discomfort. And a catheter-related complication could relate to many other events, up to lung perforation or hemothorax, for instance. So the same holds true for the LLT respiratory complication associated with device. They are very general. So what to do? Based on what we just saw, it is advisable, first of all, to supplement the PTC guidance for coding of medical device and post-procedural complications in your own in-house coding conventions to ensure accurate and consistent coding output. You saw that the guidance that is provided is really very short, and you could see with our example here that we have a lot of possible code assignments we could choose from. So it's really very important to provide guidance to coders here to achieve coding consistency. So you may split code if no combination term is available, but may also decide to prioritize the information received if splitting is not an option for you. Here are the final suggestions for this verbatim. You may split code and assign chest discomfort and LLT catheter-related complication in order to capture all information. But you may prioritize the information received and decide to only code the medical condition, ignoring the relationship to the pleural catheter to the device, because you can, it's not related. If it's a device that you are testing, a pleural catheter, of course, you could document the relationship to this device in a separate database field. Same holds true if this is just an incidental finding, then it would not be related to your investigational drug or your suspect drug in PV. Or you may decide to prioritize the relationship to the device and code to LLT medical device discomfort, losing the exact anatomical site which is affected by the discomfort. So I personally wouldn't go for the medical device site discomfort or the catheter site discomfort because both seem to be too narrow for what is reported here. It's not just the catheter insertion site causing discomfort, but the whole chest is affected. But you have the choice. Document your rules for coding such terms so that your coders know how to approach these terms. And one additional comment, for coding of post-procedural events, it may also be helpful to define the time period that would allow for classification as post-procedural, whether symptoms like pain or discomfort that occur within a period of 1, 2, or even 4 weeks after a procedure can still be considered post-procedural events. So what is the time period? So it may be helpful to define such a time period to provide guidance to coders as well. Next example for a reported post-procedural complication. Here we have a surgical wound abscess that is reported. So is this meaning clear here of this verbatim? Can we capture all details with MedDRA, or do we have to look for suitable synonyms because we don't get an exact match? What would be the most appropriate LLT? Which LLT would you select? Surgical wound abscess. Surgical wound infection. If you look into MedDRA, you will see that infection and abscesses are represented separately on PT level because, yes, an abscess is an infection, but it's a specific type of infection, encapsulated infection. Surgical wound infection, post-operative wound infection, post-operative abscess, yes. But post-operative abscess can't be anywhere. Does not mean that the surgical wound is affected. You may want to split here. Incision site abscess, interesting. Post-operative abscess, well done. So let's browse MedDRA again and see what we can find. So if I look for surgical wound terms and see what I can find, we have the surgical wound infection and we have a post-procedural site wound infection. So this is all that we have. If I replace surgery by operate, then we have post-operative wound, breakdown, infection, necrosis, but no abscess. So what could we do? We have the wound abscess. Let me look for wound abscess. Here we are. And we get a hit here, wound abscess. Same PT. And if I look into the hierarchy, I see that this is grouped under, it is grouped in SOC injury, poisoning, and procedural complications, but it's not represented as a procedural complication in this hierarchy. It's grouped under HLGT injuries, NEC, not elsewhere classified, and under HLT non-site specific injuries, NEC. So it's not represented, this term is not represented as a post-procedural complication, so would not be suitable for our verbatim. Now we will have to look for synonyms. Surgical wound. A surgical wound is an incision into the skin, so it is an incisional wound. And one of you have already proposed the incision site abscess here. So you could replace the surgical wound, operative wound, by incision site, and then you would have incision site abscess. Here it is, perfect match for our verbatim. And you can see that this term, incision site abscess, is grouped under HLT non-site-specific procedural complications, under procedural related injuries and complications, NEC. So it's represented as a procedural complication. It's a perfect code assignment for our reported condition. Let me switch back to the presentation. So what could we learn from this? We would, of course, want to capture the specific complication at the surgical wound, meaning the abscess. But because not all possible complications can be captured by specific MedDRA terms for surgical wound complications, we will have to check for medically appropriate synonyms in some instances. When searching, we will have to ensure the appropriate placement of a given term in the MedDRA hierarchy in SOC injury, poisoning, and procedural complications. And you could see earlier that the placement of LLT wound abscess would not be appropriate for our reported condition because it's not grouped as a post-procedural complication term. And if you decide to use an appropriate synonym, make sure to document your rules in the coding conventions that you have. And our final suggestion is to code surgical wound abscess to incision site abscess. Any questions, Jane?
Questions on that one? No questions, Caroline, on that one.
Okay, then let me continue. Now, our next example, it is reported that a patient had scars from multiple abdominal surgeries. Such a finding would rather be reported as a medical history condition, but it really depends on the product you are looking at, rather not as an adverse event or adverse reaction. So it could be if you have a product that enhances wound healing, that or is used for treating scars, then this may also be an indication, but mostly you would see this as a medical history finding. We would first look for a combination term here, but if not available, either splitting or again prioritization of the information will be required. So which LLT would you select? Scars from multiple abdominal surgeries. Would you code this to abdominal operation, abdominal wall operation, surgical scar? Would you split code, or would you seek clarification? What would you do? Let us check. Most of you would code to surgical scar. Some would split code or seek clarification, and only a few of you would code to abdominal operation. Okay, let me close the poll and again check in the browser. So if I enter scar and abdomen and search, I don't find anything. So then let's look for scar and operation. Oops, again, I'm not a good typer. You see that operation was already replaced by the synonymist that is incorporated in the browser to surgical scar. So we have a term, surgical scar, and most of you have proposed this one. It's an LLT under PT scar, so quite a general term. But we could, of course, also code to the actual surgery and check whether we have a term for abdominal surgery or abdominal operation. Here is the abdominal operation. Here it is. It's, of course, grouped in surgical and medical procedures. And if we go to browser, whether there are more specific terms underneath, it's just abdominal operation. So these are the terms that we could use. Let me switch back. So when taking a coding decision, one must consider the type of data that is reported. Here it is medical history information, most probably. If you're a coder, mostly you know what you're coding. So in clinical trials, it's separated between medical history, adverse events, or other types of data that you have in the CRF. So usually you know what you're coding. It is useful to have coding conventions in place for such scenarios like this one here, that is quite frequently reported for medical history findings. So you have the option to either prioritize the information or to split code here. In my previous company, we have taken the surgery as priority and would have coded such a term to LLT abdominal operation. Here it is. But one could, of course, also decide to split or to code to surgical scar only. But LLT surgical scar is grouped under PT scar. I mentioned this already, quite a vague term. So capturing the abdominal surgery provides more medically relevant information in my view. But it is up to your organization how to handle similar terms. Anyway, document again your rules, train your coders, and apply these rules consistently. Any questions, Jane?
Yes, the question we have is, can you give us any insight into why the surgical wound infection goes to postoperative wound infection rather than incision site infection?
Yeah, because there's only few postoperative terms or surgical wound terms in MedDRA. So you really have to sometimes use synonyms in order to capture most of the information that you have in your verbatim.
That's the only question, Carol Ann.
Yeah. So then I hand it back to you, Jane.
Thank you very much. So hopefully you can see my screen now. Our next example is exacerbation of supplementary motor area syndrome, including paresis and ataxia of the left leg. So this was an example sent in to us. This one actually came into the help desk asking for guidance on it. And after a bit of to and fro discussion, we're including it as one of our examples. So the question we would always ask here is, are we clear on what exactly is being reported? Can we reference it? And have a think about what type of report is it? You will know the context of what else has been happening to that patient. But overall, we're looking to capture as many of the details reported as possible and then ultimately select the closest LLT or LLTs. So our first thought then is the medical referencing. What is this? It's supplementary motor area syndrome. So we found a reference here that we share with you that says the supplementary motor area or SMA syndrome is a characteristic neurosurgical syndrome that can occur after unilateral resection of this area. Clinical symptoms may vary from none to a global akinesia, predominantly on the contralateral side with preserved muscle strength and mutism. A remarkable feature is that these symptoms completely resolve within weeks to months. So the things that jump out to me here from reading this is that it is a characteristic. It's a post-operative complication. We can understand it following brain surgery, but it tells us here that the clinical symptoms can vary. So in our verbatim, it tells us that they've told us what the symptoms are, and normally, as you're probably all aware, in the PTC, it says that the preferred approach is to just code the diagnosis and not symptoms of things. But here, these are, you could say, are they symptoms? Are they consequences? But because the symptoms vary with this syndrome, I personally would think clinically it's important to capture the details of the actual symptoms. And also what they make there, I see is in the verbatim, it says it's an exacerbation, yet the reference says this condition should resolve spontaneously over time. So that makes me aware as well that it is worth capturing exactly all that we know, as much as possible we know of what's going on with this patient. So those are the first thoughts I have. And now I'll go to my browser and have another look and see what we can find. So let's look for it first of all. Supplementary motor area. It seems that that's the name for it from that reference. There's nothing with that word in it. Let's have a look at motor area, in case there's maybe another way of saying it. You would spend time doing your research here. No. So it's a procedural complication, isn't it? A neurological, a brain operation. So let's have a look. Neurological procedural complication. Let's see if we can find anything even to get us in the right area of MedDRA. Neurological procedural complication, that might be the best we can do. Let's have a look. Neurological procedural complication. We can see the hierarchy of that on the right-hand side here. It does go to injury, poisoning, and procedural complications because it clearly is priority as it's a complication there. So that's an option. I can't think of anything else. Let's have a look at our symptoms and see what we can find for those. Ataxia was one, wasn't it, of the leg. We're looking for a leg ataxia. So we've got ataxia with the exact match, and we've got 32 other terms that we can look through here. We can look through vestibular, that's because ataxia can affect the balance. Cerebellar ataxia, against, no, that's not it. Ours is a leg. So what do we, hemiataxia, but hemiataxia would suggest the whole half a body. That's not what we've got. Motor ataxia, that might be a good one. Motor ataxia there with a PT of ataxia, or otherwise it's just ataxia, isn't it? So maybe that's the best we can do. Ataxia of some sort. And then we could look up paresis of the leg. Should we look up paresis of leg? That's what we've been told. Let's try for that. See if there's a leg, or then if not, there might be a limb. No, there it is, leg paresis, which has a PT of monoparesis. That looks quite good because it is only one leg affected. So I like the mono at the PT level there. Bilateral leg paresis, no. So leg paresis, that's the wording we've been given, and ataxia, and we can't do much with the complication there. Just let's have a look. What I'm going to do just before I leave that is to just check the supplemental, let's see, this, I know that the requester on this one we had some discussion, and I know that they did submit a change request. So let's have a look and see. I've changed the settings in the browser here. You can only do this in the web-based browser, but I've changed it to the supplemental view. And this is what shows you terms that have been approved for release in MedDRA, but they haven't yet been released. They're waiting for the next version. So they're waiting to come out in September this year into 24.1. And there is the term that was requested. It has been approved. It's an LLT and PT. And if we look at the hierarchy of this on the right-hand side, we can see that it is a procedural complication. So that's what we'd expect. So sometimes looking at the supplementary terms, although you can't use them, they do give you some guidance on the placement of the terms. So that's something you might want to bear in mind when you're doing coding. And certainly before you submit a change request yourself. So having done all that, what would you do now? I've given you the options for the terms that I showed you, plus a couple of others. We've got leg paresis, ataxia, ataxic hemiparesis. Well, ataxia, what you make of that ataxic hemiparesis, neurological procedural complication, post-operative complication, or would you seek clarification? We haven't mentioned that as an option, but would you seek clarification on this? Just watching the numbers there as you vote. I can see how many of you are voting. Can't see who's voting or what you're choosing, but I can see the numbers of the votes coming in. A good number of you voted so far. Let's wait a few more seconds. Okay, that looks stable now. So this is where your votes are lying. Most of you agree with me with neurological procedural complication seems to be the best we can do for the moment. That's more specific than post-operative complication. I know that post-operative, it sounds like it's more of a surgery, whereas procedural, post-procedural, but it is a neurological procedure. So MedDRA treats procedural and post-operative as synonymous. So I'm happy with neurological procedural complication. Ataxic hemiparesis. This one, I'm not so keen on this because hemiparesis is one half of the body, and we know that it's only the left leg affected. So although the term looks quite nice because it combines both ataxia and hemiparesis, or paresis, I don't like the fact I'm making it into a hemiparesis, and I would only use that if I knew that it was the whole side of the body affected. I would prefer to capture the symptoms of ataxia and leg paresis. So that's what I would be looking for. And our learning points there are that we do need to refer to medical references to fully understand it, be clear of the context in which it occurs, so we would know that the patient's had some brain operation, and then we would search for a MedDRA term, search MedDRA for a suitable LLT that captures the neurological complication, and consider whether to code symptoms separately, which I mentioned about capturing symptoms separately, and then we would request a new term. Here the term has already been requested, but that's where it came from. So that's our points there. Our final selection is neurological procedural complication, leg paresis with a PT of monoparesis, and motor ataxia or ataxia, with the PT as ataxia would be the same. Okay, so do we have any questions on that one, Carol Ann?
Right, let me check. No.
No question.
What do we do with the exacerbation was one question.
Well, there wouldn't be an exacerbation of the condition. MedDRA doesn't add exacerbation or worsening now. There are a few terms in MedDRA with either aggravated, exacerbated, but they're legacy terms that date right back. So if you were working in drug safety and it was possible to capture several terms, you might want to choose a condition aggravated if you wanted to capture the fact that the syndrome is worsening. But generally the PT in these cases, you find that the PT is only the basic condition anyway, so you're not really gaining anything by doing that. I took it into account myself by thinking that it is worthwhile to capture the symptoms and to know exactly what's happening, but there's not a lot we can do with it other than selecting another term to capture the fact that it's worsening. Because it's not a pre-existing condition, is it? It's not pre-existing, it's something that has just occurred. So no more questions?
No more questions.
Thank you. So I'll move on to my next example. This is a gas cataract. Let's see what type of term this is. Gas cataract, do we know what this means? What's being reported here? And are there any suitable synonyms for it if it's not in MedDRA? But what would be the most appropriate LLT overall once we've done all our research? So we've done some medical referencing to bring along to show you today, again, in the interests of time. And one of the articles we found was that sometimes when there's been some eye operation performed, particularly when it's to fix a retinal break, repair a retinal detachment, or repair a full thickness macular hole, they can use a gas bubble that's inserted into the eye, and this acts as a tamponade, pressing the retina back into place and helping to seal any hole or tear. So it's part of the procedure that may be done for another problem. Okay, so this is what we picked up from this article. So it's not that the patient's it's not a lens replacement. It's usually a procedure done to correct a retinal detachment or retinal problem. But one of the complications of this is that when you're then moving the vitreous out of the way, the lens is exposed and there's oxygen can get to the lens itself. And this, through diffusion, it increases the oxygen pressure. The lens normally absorbs oxygen by diffusion. The vitreous acts as a barrier. That barrier is taken away, and so there's more oxygen available. This causes oxidation, and it can cloud the lens. So it is a type of cataract. It's a nuclear cataract is what happens when we did our research. So the center of the lens, and it's as a consequence of having this gas bubble. So it seems like it is a complication, again, of a surgery, a particular eye surgery. What would you code this to? Some of you may have done some research beforehand. We sent the verbatim terms out in advance. Cataract operation, complication. Again, cataract operation, complication. Eye operation, complication. Secondary cataract, the nuclear cataract. Ocular procedural complication. So quite a few of you going for this cataract operation complication. This is interesting. I wouldn't select that because it wasn't a cataract operation that was being done. It was a retinal repair that was being done. And so that term, cataract operation complication, is used when you've got complications after a cataract replacement or an intraocular lens insertion. The cataract itself was the complication. It was the result of the procedure, not the reason for doing the procedure. So that's why I wouldn't choose that one. But it's good to see. Thank you for sharing your views, all of you. So let's have a look in MedDRA and see what we can find. I'll go back. I'll change my browser back to the regular, restore the defaults here. So we've looked at our references. We'll go and we'll browse and we'll see what we've got. So we've got, let's look up our gas cataract first of all, just to check it's not in there. No, there's nothing there. So it's a post-operative complication, isn't it? Let's have a look at eye procedural complications and see what we've got. It seems like it is, but if you're unsure and you're, even after doing your research, you're not convinced on what it might be, you can always query, but let's have a look. Eye operation complication has a PT of ocular procedural complication. So that's the kind of area I'm looking for. It's a definite complication as a result of having the procedure. So let's have a look at the brothers and sisters of that term. There it is, ocular procedural complication. And there's 3 terms underneath it. We could have a look at some of these other ones. I'd need to look them up. I don't always know what the specific eye terms mean, but we could have a look at other things there. And this is where we'll find our cataract, post-cataract operation complication that you found. But as I mentioned, I wouldn't use that one because that's when the operation is to replace the lens. So that's probably the closest we're going to find in that one. We could also, we've got the fact it's a complication. What about a cataract? Is there a specific cataract term that we could use? So we did this session this morning, and we was some debate amongst our attendees about the meaning of after cataract. So this is this term after cataract. You see the top of the list there. That is a procedural complication, but again, it's when the lens, it's a cataract that appears through the capsule, posterior capsule after the lens has been removed, or it's a cataract. It's when you're replacing the lens. So that's different. That's not what we've got here. We've got a cataract appearing. It's the actual natural lens that's developing a cataract. So I think there's our cataract nuclear. One of our references said that these cases, these gas cataracts, are nuclear cataracts. Or we've got a traumatic cataract. Not really, is it traumatic? It's surgical, and somebody suggested secondary was another one that must be in this list as well. Nuclear cataract. I quite secondary cataract. So we'd be looking for a cataract term that also has a PT of cataract. So we would go to our browser, look at the options there, look through these cataract terms and pick up one that you think is, although it is a complication, it is a cataract, and people can end up having that removed and an artificial lens inserted if it doesn't clear after having this sort of procedure. So you'd choose the closest cataract that you feel suits you. I like the nuclear cataract, and we'll go back and see then what we've learned. So our learning points is that we would research the condition and the possible cause, consider what you know. Is it an eye clinical trial you're doing, or does the patient have history which would support this being a procedural complication? But if you are unsure, you've always got the option to clarify if possible, and if it hasn't come from a consumer or somehow that you can't trace it. Our final suggestions here is that we would seek clarification if we were uncomfortable, but if we're happy on what we've researched, we would code it to ocular procedural complication with an LLT-PT also of cataract nuclear to capture that. We would consider also maybe if gas cataract is a commonly used phrase and we think it's not in MedDRA, we could consider adding it as a change request. So that's what we would do with that one. If we got any questions, Caroline, on that one? Any thoughts? Anyone?
No questions.
No questions?
No questions.
No, that's good. So our next example, another complication here from a procedure is, and it also, like the other one, it was a suggestion from one of our attendees, is how would we code aortic root to right ventricle fistula following TAVR? Wow, what's being reported here? We need to be clear on what's happening. It sounds like it's a procedural complication, but what is a TAVR? Is this a documented complication? Is there a combination term perhaps for this? Or should we select 2 LLTs for it? Similar to our thought processes in the previous example, really. So firstly, I've looked up in Dorland's. That's our go-to medical reference dictionary. So I've had a look, and TAVR stands for transcatheter aortic valve replacement. So that gives us something there. We would need to look up what is that procedure, but at least we know what it stands for. And then I've had a look here. We're probably all familiar with the word fistula, but just to give you there a reminder, a fistula is an abnormal passage or communication, usually between 2 internal organs or leading from an organ to the surface of the body. So it's some kind of abnormal channel that shouldn't be there. And we've done some research ahead of the session, and this is what we found. Aortocardiac fistulas after a TAVR are rare and mostly manifest as complications of an external trauma or infective endocarditis. So the target area for these fistulas, where they tend to occur, is a 2 by 2 centimeter contact surface between the aorta above the right coronary cusp and the right ventricular outflow tract. And these are ultimately, the fistula may result in right heart failure because the heart won't be pumping effectively. So this is what we know about it. And so let's find out more about the procedure. What the procedure is they thread a catheter through the femoral artery up to the heart, and it goes via the aorta to replace the aortic valve in the heart. So by doing this, it's very close proximity to replace the valve between the right ventricle and the aorta where they're doing the work. So it would be not uncommon for there to be a trauma, or perhaps the prosthesis doesn't fit properly, or there's an accident, some kind of perforation and a fistula can occur, especially when you think about it, they're removing the calcified tissue, removing the valve, the old valve, and so it may be that there's thickening and the tissue is already vulnerable to trauma. So this is the kind of thing is what we're dealing with here with this report. We did some research into it as a complication, and we found an article showing that aorto right ventricular fistula is an occasional finding, just as I've explained, because of the proximity to that area when they're doing the operation. So we can have a look in MedDRA. Let's go to our browser. I've gone through that quite quickly. Let's go to our browser and have a look again. We would be wanting to capture the procedure. If it hasn't already been reported separately, you'd check in your case, has it been captured separately, the TAVR? Let's see what we've got. Transcatheter I've searched on, and we found the first term in the list there, transcatheter aortic valve implantation. Well, our TAVR said replacement, but implantation is exactly the same. We're talking about replacing the natural tissue catheter with an artificial tissue valve with an artificial valve, so transcatheter aortic valve, and it's a cardiac valve therapeutic procedure as we'd expect. So that's what I'd be looking for with to capture the procedure. And then we've got the fistula. So how we go, let's look at ventricle. Ventricular, I'll just put the word stem in for a fistula, see if there is anything in MedDRA. No, nothing there. Let's look up aortocardiac, aortic, aorta, search, fistula, see what we capture there. Well, there is an aortoatrial fistula, but in most cases these would be so what have we got here? We've got it could be a procedural complication, this one, a malformation or an anomaly. Sometimes cardiac fistulas are a result of aneurysms that burst, really. So things like this can happen spontaneously, but aortoatrial is not what we want. We wouldn't choose a term which is close but wrong. We never do that when we code. We'd go more general. So we'd be looking up, there's no kind of cardiac fistula that I'm aware of. Let's have a look. Cardiac or heart, the browser will search for both words. Is there a cardiac fistula? No, there's nothing there. So we end up again with a complication term, looking for a procedural complication. Is there a procedural complication from valve replacement? Like you told me there was an eye, a cataract procedural complication. Is there a complication following valve replacement or valve operation? So let's have a look for that and see if we can be specific in some kind of, because it is a complication. Cardiac valve replacement complication. That's the kind of term I was looking for. Cardiac valve replacement complication. There's the PT for it. And as we'd expect, it's with the other complication terms. So that's without having a fistula term available. This one actually has the benefit of linking it to the procedure, and we can see the complication. And if you might again want to request it through a change request to add the aortoventricular fistula, and then you could select the complication and the fistula and the actual name of the procedure so that you capture all the information through separate terms. But that's where my thoughts would be going on this one. Oh, and I've given you the poll, but actually I've told you the answer. It's hard to do the browse without giving you the answer. So let's go through this quite quickly then, see what you've got. So those of you who have voted agree with me, cardiac valve replacement complication. I wouldn't choose the aortoatrial fistula because it was very clear in our report that it was the right ventricle. Fistula you could choose, or post-procedural fistula, but they're very general, aren't they? I preferred the cardiac valve complication. The fistula doesn't tell you a great deal. And ideally, perhaps in time, we could request that a suitable term is added. So if you've got any questions or comments on that one, please do share your thoughts with us. We wish we could all meet up in a classroom and hope that we will be able to soon. There's our final score on that one. So the learning points here, while you get your thoughts together, is that we would reference the complication and the procedure, search MedDRA for suitable terms for both the procedure and the complication, make sure both are captured. And if we are unsure, again, once you've done all your research with any term, if you feel that it's not making sense and medically doesn't seem right, you can always query. But in this case, I felt quite comfortable in what we are able to research based on what the reporter had told us. So my final suggestions there is transcatheter aortic valve implantation to capture the procedure, cardiac valve replacement complication as the general term to capture the complication, and then I would consider a change request to add something more specific into MedDRA with to complement the aortic atrial term that we saw. So that's my ideas on that one. And with that, if we've got any questions, Caroline, I'm happy to discuss.
No question.
Have you got anything to add to that, Caroline? It's a term we discussed in detail before the session. Anything that you think needs clarifying, or anything to add yourself?
Well, the TAVR, so this transcatheter aortic valve replacement, this complication afterwards is quite rare. So there are only a few cases that were reported in literature, but this fistula is relevant because it may also occur because of aneurysm at the aortic root, ruptured aneurysm. So it's quite frequent, not frequently, but more frequently occurring due to this underlying condition. So it would be worthwhile to submit a change request, not for the TAVR related fistula, but for the others.
Because we saw the placement of the fistula was only secondary into the injuries. It was primary, wasn't it, to the vascular?
Yeah.
So, thank you for that. So I'll hand over to you now for the next example.
Here we are. So one of our participants asked us to address more eye-related verbatims because ophthalmology is an area coders are not so familiar with, and therefore they may have difficulties with these sometimes quite unusual and also complex terms. We already discussed the gas cataract as a post-procedural ocular complication before, and in this example now it is reported that pigmented vitreous cells were found in the right eye. So is this verbatim clear enough to code? Do you think that we can directly code it, or do we need to query it? Is this a diagnosis, or is it just an investigational result, an investigational finding? Are there any suitable synonyms that we could use for this finding? And what would be the most appropriate LLT in your view? So we will first need to understand what this is all about and in which clinical situation this sign can be seen by checking medical literature. Here it is stated that if a PVD, so a posterior vitreous detachment, is associated with a retinal break due to tractional forces on the retina, pigment from the retinal pigment epithelium is released into the vitreous gel. And this pigment can then be seen by slit lamp investigations as a fine dusting of brown cells in the anterior vitreous body. And this is called tobacco dust or Schaefer's sign. And it has been shown that the presence of these pigment granules in the vitreous or in the vitreal body in the absence of previous ocular surgery is almost pathognomonic, so really indicative of a retinal break due to a vitreous detachment. The next reference confirms the fact that Schaefer's sign is practically pathognomonic of a retinal tear or separation of the neurosensory retina from the underlying retinal pigment epithelium. So this occurs when the vitreous body detaches from the retina. Due to these traction forces, then the retina is injured. So either a tear can occur or a complete separation of the layers of the retina. Here an image how the Schaefer sign looks like. You see these clumps of pigmented cells in the vitreous body, and this is why it's called tobacco dust or Schaefer sign. Now, how would you code? Which LLT would you select for this verbatim? Pigmented vitreous cells right eye. Would you select LLT vitreal cells, or would you code to vitreous detachment, to vitreous degeneration, vitreous opacities, or would you keep it more general and say, well, I would code this to LLT vitreous disorder? What would you do? Many of you are still thinking how to approach this. Vitreal cells would at least capture the location and that there are cells in the vitreal body. Vitreous detachment is the underlying diagnosis leading to retinal trauma and then to this sign, to the Schaefer sign. So let's see so we have a split of opinions here. 1/3 of you would rather code this more generally to vitreous disorder. Others would consider this vitreous opacities because it's pigmented cells, so somehow opacity in the vitreous body. Others would code to vitreous cells. So split of opinions here. Now let's check in the browser again. Here we are. So if I enter vitreous and pigment, I don't find anything. No results. So if I enter vitreous to capture vitreous and vitreal and cell and search, then I find the vitreal cells. I can now do a right mouse click, go to the browser and see if I find some more interesting terms amongst the neighbors, but there's nothing. Choroidal, vitreal, vitreous adhesions, degeneration, nothing more specific underneath. Floaters, vitreous floaters. But it's not debris that we have here, but it's really pigmented cells. And here are the vitreous opacities, also nothing more specific underneath. So what could we do now? So there is no suitable term available. You may now consider to submit a change request. But again, before submitting a change request, always check the supplemental view in the browser and check whether such a term was already requested. So if I go for Schaefer and search, then I see that Schaefer sign has already been requested. It's a supplemental term, so it's not yet released. It will only be put into production with the next MedDRA version release, 1st of September. So you see can identify these supplemental terms via the green dotted line around it. And if I click on it and go to the browser, you can then see the hierarchy, and you see that also the vitreous tobacco dust has been added to the terminology as a supplemental term already, and both are grouped under PT vitreous detachment, because this vitreous detachment leads to the retinal trauma, leads to the fact that the pigment from the retinal epithelium is released into the vitreous body and leads to this Schaefer sign. So here it is associated with the vitreous detachment. And as literature indicated, this is really pathognomonic. So it's really indicative. It does not relate to any other indication. It's related to a vitreous detachment with retinal separation of the layers or retinal tear. Okay, so let me switch back to my presentation. Our learning points are to first get, of course, a clear understanding of the condition and its possible causes. So use medical references in order to get a clear picture on what is being reported here. We would then look for suitable terms in the browser, also using synonyms when not finding an appropriate match in SOC eye disorders, and doing bottom-up and top-down searches in the SOC to check the neighbors whether some more specific terms are available. And if not finding anything suitable to capture the reported condition, we would consider the submission of a change request. But before doing so, as I've demonstrated, it's always good practice to first check in the supplemental view, because the term that you have in mind may have already been requested by another MedDRA user. So this would then save you time and would also show you where this new term will be placed in the hierarchy. And our final suggestion is to code this term to LLT vitreous detachment, which is identical to the PT under which the supplemental terms vitreous tobacco dust and Schaefer signs are grouped. Any questions, Jane?
No questions on this one, Caroline, no.
Okay, then I will continue. Now, the next example now relates to a different area, namely coding of neoplasms. It is reported that the pleomorphic adenoma was excised from the left parotid gland. So is this verbatim clear and unambiguous? Do we know what type of tumor this is? Is it benign or is it malignant? And can we capture all details, including the affected site and the histology with a MedDRA term, plus the fact that it was surgically removed? So is there a combination term available that would capture everything from this verbatim? First, we will check Dorland's. So Dorland's describes the tumor as a benign, slowly growing tumor of the salivary glands, and histology shows the variety of epithelial and myoepithelial cells, as you can see on this image here. These adenomas account for 80% of all tumors of the parotid gland, and 5% of them can undergo malignant transformation. Because of this relatively high rate of malignant transformation, they are usually treated by parotidectomy. But alternatively, also an extracapsular extraction of this tumor can be performed. So only a partial excision of the parotid. Okay, now we have a better understanding of this tumor and how it is treated. Let's now check in the PTC document for MedDRA term selection whether we can find some guidance on how to deal with such combination terms that contain both a diagnosis, here the adenoma, and a related procedure. Here we are. If a procedure is reported with a diagnosis, the preferred option is to select terms for both the procedure and the diagnosis. But alternatively, you can also select the alternative approach and select a term only for the diagnosis. And here's an example. It is reported that a liver transplantation took place due to a liver injury, and the preferred option is to code both the condition leading to the surgery, so the liver injury, plus the specific surgery, the liver transplantation. And the comment given here, the rationale for this approach is that selecting a term for the procedure, that especially here, this may really indicate the severity of the condition, would reflect this severity of the condition. But you are free to choose either of these options. You could also choose the alternative option and just code to the underlying condition, that is the liver injury. Now it's your turn again. Which LLT or LLTs would you select based on what you have just heard? So our verbatim was pleomorphic adenoma excised from the left parotid gland. It's a specific salivary gland that is affected, and we have the exact histology of this tumor, pleomorphic adenoma. Parotid adenoma, yes, it's an adenoma, but we have more histological information. So MedDRA contains terms that are more specific. Yes, pleomorphic adenoma, we have it. Exactly, pleomorphic adenoma. So two suggestions here, parotid adenoma or the pleomorphic adenoma. benign tumor excision and pleomorphic adenoma, so splitting in order to capture both the neoplasm and the surgery. Now, yes. Now let us check again in the browser. Here we are. Let me switch back to the released version 24.0. So when I enter pleomorph, and search, I get quite a number. Here is my pleomorphic adenoma. And if I click on it, I see it's grouped under lip and oral cavity neoplasms, benign. And if I go to the browser, right mouse click, and check this PT, I see that under this PT we have the mixed parotid tumor. And so you could capture both the exact localization, the mixed parotid tumor, and the histology in one term, because the mixed parotid tumor is grouped under pleomorphic adenoma. So we could really code this to mixed parotid tumor. But there's nothing available. We saw that pleomorphic that would combine this type of tumor with its excision, with a surgery to treat this tumor. So we would need to split this term. You have suggested to select a benign tumor excision term here in this instance, but as I mentioned before, so the way of treating this neoplasm because of the malignant transformation is a resection of this tumor, either only a partial resection of the parotid gland or a complete resection. So parotidectomy, let me check. Here we are, parotidectomy. If I go to the browser, I can check whether there's a partial one as well. But here, this is parotidectomy. It's one PT, only one LLT underneath, identical to the PT. So this is the one that we would choose. We learned that this is the surgical resection of this tumor is done by either partial or complete resection of this salivary gland. Let me switch back. So what could we learn from this verbatim, from this example? We first had to use medical references again to better understand the reported condition. And based on the PTC guidance, we started with searching for a combination term, but had to recognize that splitting of the reported information is necessary because no specific combination term was available. So when selecting a suitable LLT, you will have to decide whether histology or the affected anatomical site should take priority. So this is always a general decision that has to be taken for the coding of neoplasm, including also the staging, because sometimes you get combination terms with localization, specific histology, plus staging, plus, and sometimes you don't find a term that would cover all this information. So you would then either split, duplicating these events, or you would need to prioritize this information. In our instance here, the pleomorphic adenoma of the parotid gland was easy going because we had an LLT that captured the parotis, and this was grouped under a PT that was called pleomorphic adenoma. So we have captured all this information of the verbatim, but this is not always the case. So you will need some rules, prioritization rules, for coding neoplasm terms, malignant, especially the malignant ones. So your approach may depend on your product portfolio and will have to be agreed with the respective product experts. If you have come to an agreement, then please document your rules in your coding conventions to ensure that these coding scenarios are handled consistently within your organization. So as an example, for instance, if you get a squamous cell carcinoma of the hypopharynx stage 4, you won't capture this information with one MedDRA term. So you will have to decide whether you prioritize the staging or the histology here, the squamous cell carcinoma, or the localization. So our final suggestion, split code and assign mixed parotid tumor under pleomorphic adenoma, and select LLT parotidectomy in order to capture the excision of the parotid gland. Any related questions, Jane?
No questions, Caroline. No
Okay,
questions.
next one. Next one, here it is reported that benign liver cysts were found. Can a cyst be considered a neoplasm or a tumor, and could this verbatim be coded to a benign hepatic neoplasm term, or just to LLT hepatic cyst, ignoring the attribute benign? Do you have in-house coding conventions in place that cover this specific topic? Or how would you code such verbatim? So how would you approach this verbatim? Benign liver cysts. Hepatic cysts, yes. You would ignore the information benign in this instance. Yeah, most of you go for the hepatic cyst. Benign tumor of liver would be another option in order to capture this attribute that it is a benign. Is technically benign to so code to hepatic cyst. Okay, so let's close the poll. Thank you for joining and look at some definitions. So in Dorland's, we are told that a cyst is an abnormal closed cavity in the body lined by epithelium and containing a liquid or semi-solid material. So the definition provided does not put cysts into the context of neoplasms. Cysts can only be considered as neoplasms when they are classified as malignant, as shown in a description for pancreatic cysts provided by Stanford Healthcare. Here it is stated that malignant pancreatic cysts are cysts that harbor cancer or have the potential to become cancer, and they are characterized by cells that secrete mucinous material into the cyst. So these would be considered neoplasms, or more precisely malignant neoplasms of the pancreas. The website of the Mayo Clinic also refers to the difference between a tumor and a cyst. They say that cysts that appear uniform after examination by ultrasound or a computerized tomography scan are almost always benign and should simply be observed. But if a cyst has solid components, it may be benign or malignant and should have further evaluation. And the best test to determine whether a cyst or tumor is benign or malignant is a biopsy. And the image below illustrates what I just said. Here we can see a suspect ovarian cyst, so a suspicious ovarian cyst with solid components, here solid components, and multiple septa. You see the septa here. Another suspicious sign that may indicate malignancy. It was finally diagnosed to be a high-grade papillary serous carcinoma based on histological examination. So the PTC guidance for MedDRA term selection does not specifically address the coding of cysts. but some helpful explanations are provided in the MedDRA introductory guide, not for cysts, but for a different but somehow comparable concept, the polyps. There it is stated that unqualified polyp terms in MedDRA currently default to a benign classification, and that within SOC neoplasms, polyp terms are linked to HLTs that represent the benign types rather than the malignant or unspecified forms. Polyp terms with the qualifier malignant will no longer be added to MedDRA. Instead, it is recommended that MedDRA users refer to the available malignant neoplasm terms for coding purposes. So now let's have a look again into the browser. Here we are. So if I enter benign cyst, I will find some hits. I will find lung cyst benign, that is grouped under lung cyst. I will find ovarian cyst benign, again grouped under ovarian cyst. So if I look into lung cyst, here you have, they are all these cyst terms are similar to what we saw for the polyps, are grouped under HLTs representing benign conditions. And most of you have suggested to code our verbatim to hepatic cyst. So let me now check for the liver cyst, the reported liver cyst. Here we are, and search. Now again, the synonym list replaces liver by hepatic. Here is our hepatic cyst. We don't have a benign cyst, so hepatic cyst would be our selection. Here it is, hepatic cyst. And again, you can see that it's grouped as a benign condition under HLT, hepatic and biliary neoplasms benign. So the hierarchy captures the attribute benign. What about polycystic liver disease? So we had several cysts that were reported. Would this be an option? Don't select a term without checking the hierarchy. So when checking the hierarchy of this PT, you will see that this is a congenital condition. So it's a congenital familial genetic disorder. So always check the hierarchy if you find terms that seem to be suitable, but where you are not quite sure whether they are really appropriate. So this would not be an option. Hepatic cyst would be the best approach here, but you may of course also decide to capture the fact that this was a benign condition by saying, well, it's a benign liver neoplasm, it's a benign tumor of liver, and you see that we have plenty of terms, plenty of LLTs here under PT benign hepatic neoplasm. Now let me continue. We saw that it's helpful to use synonyms when not finding a direct match. In this instance, the synonym list in the browser already replaced liver by hepatic, but this will not apply for all terms, so always use synonyms or replace colloquial terms by medical terms when doing your searches. We as coders should also be aware and be familiar with the MedDRA hierarchy and the placement principles of MedDRA terms. You saw that cysts and polyps as well, they are considered benign conditions based on the MedDRA hierarchy. These terms only are named like hepatic cysts or ovarian cyst without the attribute benign, but the benign attribute is captured via the hierarchy. Be precise and code as reported. So if a cyst at a specific site is reported, code as such. When characterized as malignant, search for malignant neoplasm or cancer terms, and handling of benign cysts may depend on your product portfolio. Whatever you do, again, document your rules in your coding conventions to provide guidance to your coders and ensure accurate and consistent coding output. Our final suggestion for this verbatim is to assign LLT hepatic cyst following the MedDRA hierarchy. Here it is again. It is represented as a benign condition, although the term itself does not contain this information, or code to benign hepatic neoplasm if it is required to capture the benign aspect on PT level to better support subsequent data retrieval and analysis for your specific products. This really depends on your product portfolio. Are there any questions, Jane?
No, Carol-Ann, there's no questions on that one either. I think our audience is taking in all that you've told us and taught us today. So thank you for that. I'm looking at the time now. I see, unfortunately, we're out of time. So I shall take back the presentation and I'll share my screen to wrap up. We've got some terms left over from today. Some of you may have prepared, so apologies if you have prepared in advance. What we'll do is we'll roll those terms over to our July session. If it is your first time joining us today, we run these sessions monthly and they are recorded so long as the internet and the audio behaves itself. And so you can look back at any of the sessions that you may have missed on the YouTube channel. This is a screenshot here for you showing you that. And so we will cover these in July. We'll be back, I think it is 4 weeks. It's around the middle of July. And then we'll be taking a break in August. We won't have a session. So we'll roll those terms forward to that session. We'd love it if you could join us again. We are taking proposals. So at the end, there will be a survey. We're very keen on our survey because this whole concept of Let's Code Together is there for you, and it's there to help you better understand the thought processes behind coding. So anything that you can give us on how best to help you, ideas for topics you want us to cover, or terms that you'd like us to address would be very welcome. Tell us too how we can improve, whether you enjoyed the session or what you would enjoy more if we were to change. We've already made a lot of changes to the sessions based on what we've had in feedback. Here, just as a reminder for you, are some of the links to our website, the browsers, the frequently asked questions, also the points to consider documents there, and the training schedule. So there's plenty of space for next month. If you are free, we'd love to have you with us. This is our contact page from the website. You can see that some of our colleagues run local groups. There's a Spanish-speaking group, if any of you are Spanish-speaking with us today, French-speaking group, Russian-speaking, and then there's a Chinese-speaking WeChat group. So you can join those by scanning the QR codes from the website or from this slide. Here's our survey. So this is an instant survey. This is where you can give us your proposals for terms or topics. You'll also have a survey link sent to you, which is a slightly different survey. So we don't mind where you give us your feedback, but just do tell us what you thought of the session today and how we can improve. Apart from that, that's us. Well, I'm sorry if we're a couple of minutes over time, but thank you very much for your attention and for your participation today. Carol-Ann and I enjoy these sessions very much, both the preparation and the delivery. So it's a delight to have you with us. And otherwise, I've nothing more to add. So wish you enjoyable rest of your day and to stay safe, everyone. And I hope to see you with us next month or at a future session.
Bye-bye also from my side. Bye-bye.
Bye-bye
for now.
Bye-bye, Carol-Ann. Bye-bye.
Bye.